Welcome to CSIS Online. The way we bring you events is changing, but we'll still present live analysis and award-winning digital media from our Dracopolis Ideas Lab. All on your time, live or on demand. This is CSIS Online.
Hello, and good afternoon, or evening, or morning, depending on wherever you are. I'm J. Stephen Morrison. I'm Senior Vice President here at the Center for Strategic and International Studies, CSIS, in Washington, D.C., where I direct our Global Health Policy Center. We're thrilled today to be hosting a conversation with Dr. Anders Tegnell, State Epidemiologist of the Public Health Agency of Sweden and Deputy Director General of that agency. He's been in that position since 2013. He's an MD, he's a PhD in infectious diseases and holds a master's in epidemiology from the London School of Hygiene and Tropical Medicine. Anders, welcome, and thank you so much for making time to be with us today.
Thank you.
I also want to offer special thanks to some people who helped make today possible. From the Swedish Embassy, Ingrid Ask, the Deputy Chief of Mission, and Lars Erik Tindra, the Communications Officer, and from Anders' staff, Malin Arna, and from my team here at CSIS, Clifton Jones and John Mons are helping produce this session today. Amith Mandavili on my staff has worked assiduously over the last few weeks in pulling this all together. We'll be having a conversation. I welcome those who are in the audience to submit thoughts and questions. There's on the web page. You can submit live questions, and we'll try to blend those into this discussion. For some time now, dating back into early days of this pandemic in the spring, the Swedish approach was set apart. It was distinct, and it was all part of a broader global debate around what kind of approaches to take over lockdown versus alternatives. I think it's fair to say that the Swedish approach was characterized as hands-off, as limited, as laissez-faire, as attempting to tailor approaches to restaurants, to bars, to nightclubs, cafes, sporting and cultural events, to be more flexible, and to put a special focus on elderly care. We'll say more about that. To allow businesses to stay open with social distancing, to limit public gatherings. There were limitations, up to 50 at some point, to keep the schools open. And there was no wide-scale emphasis on mask wearing. Mask wearings tended to be at health settings. And a great emphasis, and this was very distinct, a very great emphasis on trust in government, trust in individuals to take personal responsibility for their behavior, emphasis upon voluntarism. And there was an emphasis on the individual as well as creating a network of support, so that if you stayed at home because you were ill or you had a child that needed to be cared for and needed to telework, that there was support in terms of salary and the like. And also to offer alternative. This was really meant to be a system of approach to offer an alternative to what was seen as highly costly economic and social cost of closure, a full closure, and something that could be sustainable on the long term. Now, this was a source of great debate. There were moments of crises and controversy around elderly care. There were discussions around, is this a form of herd immunity, either intentional or just that might occur as this type of approach unfolds. And there was a lot of discussion around whether this might actually emerge as a model of control. Over the course of the summer, the numbers came down dramatically. Sweden was aided by a number of things: high number of households that are single dwellers, high trust in government, high trust in science. But as summer ended, the number of cases were very low. In fact, as recently as the third week of October, there were further relaxations in terms of access to nursing homes and enlarging the numbers of people allowed to gather up to 300 for cultural and sporting events. And then we hit the current moment, which we're coming to right now, which has been one that's been much tougher in terms of rapid change and a sense of climate, sense of crisis and turbulence. Just last night, Prime Minister Löfven led a press conference, announced that sending draft legislation to Parliament on a new law that would attempt to strengthen constitutional and legal abilities to issue pandemic instructions and moving towards a new sort of national approach. From December 14th, we'll see new national tightened restrictions, a maximum of 8 persons permitted in public gatherings. Local and regional recommendations are suspended now in light of a national approach. We're seeing a very expansive role taken by the Prime Minister, multiple speeches over the last few weeks. The most that we've seen by the Prime Minister in terms of direct engagement with public in really 20 years, asserting his leadership, calling in these speeches for canceling all non-essential meetings, closing high schools, a big step, a reluctant step, and very dramatic and blunt messages about the need for the public to take this quite seriously. I think that in the views of some, this is trying to get particularly younger populations that may feel less vulnerable to take this all much more seriously. The second wave has been somewhat brutal in terms of the numbers in death counts, case counts. Sweden is now at about 278,000 cases, total deaths about over 7,000, and deaths per million, 700. And these are in stark contrast to some of the neighboring countries, which we can come back to. We've heard also a lot of intensified debate within Sweden itself, opposition and criticism and discussion around where to go forward. From members of parliament, this is a social democratic minority government, has to worry about its democratic standing. There's been debate within the scientific and medical community. The Science Forum for COVID-19, the Vetenskaps Forum has been very vocal. The Swedish National Academy is conducting a study. We've had a lot of editorializing in the Dagens Nyheter by the editor-in-chief.
Development was very good because it gave us an opportunity to have a very strong dialogue with the regions in Sweden. The regions in Sweden are very independent. We have regional level parliaments, regional level taxes, and the region really decides everything that's done in healthcare and in public health. So to have those on board, which we have a lot more now, has also been a very important consequence of these dialogues we've had. And now we can transfer them into a national view on what we need to do over the holidays, because the holidays is, of course, a worry, I think, like they are in most countries, because once we start moving around, we might start up new chains of transmission, and that might trigger another wave, which we really don't want to have at this stage.
Well, we have that same fear here in the United States. We just come through our Thanksgiving celebrations, and air traffic was something on the order of about 4.6 million people in the span of 4 or 5 days. Now it's a big country, 328 million people. And that 4.6 was normally it would be 11, maybe 10 or 11 million on a Thanksgiving in the United States. But that number has led Dr. Fauci to say, well, we're looking at a surge being superimposed upon a winter surge that's already upon us. Do you share that same fear that mobility, we can't stop people from moving, we can perhaps inhibit or encourage people to reduce the amount of mobility in this period, but we are entering a period of heightened mobility?
Yeah, we're definitely entering in a heightened mobility, and we are discussing quite a lot that then you need to make the mobility as safe as possible. To tell people, yes, you can go out and you can go and visit your cabin up in the north, but please stay in your cabin. Don't move around a lot. Don't meet other people in the neighboring cabins, but to try to celebrate your holiday up there with your family in your cabin. And then, of course, that's quite safe. It doesn't really make any difference if you travel 200 kilometers to the north or if you go to your neighbors. It's the new connections that are important. And I think we also learned some lessons from the summer in Sweden. Of course, the weather was also important, but that mixing during that time did not really cause any surge in cases. What caused the surge in cases was actually when people came back from the holidays, went back to their workplaces, because at least in Sweden, workplace is the one place you really get most of the transmission of the disease, the workplace and the family. And if we go back and look at what happens usually during a flu season in Sweden, the holiday season, the flu spread actually goes down quite a lot. And then it surges after the holidays. So I think here we are, as we often are when it comes to COVID-19, we don't really know. It's very difficult to make predictions. And of course, we all have to be careful. But I would say we need to be at least as careful after the holidays when we come back and go back to our workplaces and places where we meet a lot of people close, because that might really also cause another surge. So I think sustainability, trying to stay with the same kind of recommendations over time is really what we need to do, and to encourage people to keep on following them.
Well, it's very dramatic to see the quite strong, powerful messages being delivered by the Prime Minister under successive interventions, speaking directly to the Swedish people. That must be a pretty powerful instrument. And say a bit more about what's motivated the Prime Minister to do that. It's unusual. It's not the normal practice in Sweden to have that happen, and it's becoming very pronounced. Can you say a bit more about it?
Yeah, no, of course I'm not that close to the Prime Minister, so that I know what sort of turns around in his head. But of course, there are a number of reasons behind this, and one reason is, of course, this is a very stressful period. We just heard from the Stockholm region that the ICUs are now almost full, not quite full. So the healthcare in Sweden is once again reaching its maximum capacity, even if there is still another 15 to 20% of the ICU beds free, but they are spread all over the country, so not always that easy to use. And the other thing that you mentioned is, of course, that he gets more pressure from the opposition these days. During the spring, there was a kind of peace agreement, not officially on paper and so on, between the opposition and the government, and now we need to pull together. This is not the time to have a big debate on who is right and who is wrong. We are not really in that period in Sweden anymore. There is a lot more discussion on the political level on what we need to do and what we shouldn't do and so on. And I think that's also one reason that now the Prime Minister steps out and sort of really makes a point of how important he thinks this is, and to show that the government is really behind all of these kind of things that we are putting in place.
So there is a rising fear. We have this in many parts of the United States right now, that this surge could overwhelm our health system, and we could be entering a pretty dangerous period in which we simply cannot cope. Is that fear there very real there?
I wouldn't say so. It's very different in different parts of Sweden. I mean, Sweden is a small country, but still the regions differ a lot in the way that the pandemic now is panning out. We have quite a few regions now that are actually seeing a downturn in the number of cases. Even Stockholm is seeing a downturn in the number of cases. But of course, that does not reflect into healthcare yet, because it takes a week or two for it to reflect there. But other parts of the country, like the very south part of Sweden, is still on the increase. But I wouldn't say that we still had quite a lot more cases. We are still I think only about 50% of the cases that we had during the spring in the ICUs. We have more cases and more similar in the regular hospital beds. But when it comes to ICUs, there's still a lot of capacity there. And also, I think the healthcare, and I'm sure it's the same in the United States, has become much, much better at managing COVID-19 cases.
Yes.
We had an average period of treatment, I think, for 18 days during the spring. Now we're down to 5-6 days or something in the ICU. So that, of course, also makes it easier on the ICU capacity. But there are, especially in the Stockholm region, there's still a worry that it's going to get even worse this time. But on the country as a whole, no, I wouldn't say so. We still have quite a lot of capacity that could be put into this. And as I said, if we compare to the kind of capacity that was developed during the spring, we are still quite far off.
I see. You know, here in the United States, as of today, we have 105,000 beds, ICU COVID-19 beds occupied. And we had, at the peak in April, we had 60,000. So it's an extraordinary leap ahead of where we were at the peak. In April, we're now at 105,000 versus 60,000. And of course, our daily case counts are surpassing 200,000 quite often, which is an unthinkable number and continuing to rise. So there is this very real fear about the systems breaking and what might that look like. And that is motivating political leadership to behave differently in many places, not all, but in many places we're seeing a motivation of that. And certainly if you look at President-elect Biden's speeches, those are not dissimilar from what we've seen from your Prime Minister Littlefield in terms of the messaging that we see. Have your, in this midst of this turbulence and this changing environment, has your approach to testing changed in contact tracing?
No, not really. We had a problem in the beginning because our capacity for testing was very low. We tested, Sweden has 10 million inhabitants. We tested about 20,000 a week in the beginning because that was our maximum capacity. Now we're getting close to 300,000 tests a week. So that's an incredible increase. And in the beginning, the healthcare staff didn't really have time for contact tracing either. So there was a very dramatic period during the spring when we really had to focus on treating patients and there was not room for doing anything else. Now there's a different situation. Yes, there is a lot of focus on treating patients, but we still do a lot of testing, as I said. We do also a lot of contact tracing, even if sometimes not as timely as we would have liked it, but still a lot of contact tracing. So those systems, I think this time we really managed to keep both those systems running in parallel. And I think that gives us some hope. And we can also see when we look at our curve that we managed to flatten the curve. If you look at the shape of the Swedish curve and compare it to what happened in Belgium or Austria or like other countries a few weeks back, it really looks like this Swedish curve, just like it did in the spring. It's a lot flatter and does not peak as much, but takes a bit longer time for it to go down to a little bit more acceptable levels again.
Thank you. On masks, I wanted to ask you a question around masks and policy towards that. I know you've been a skeptic, or you've argued in terms of putting emphasis on use of masks in certain settings and been reluctant to argue for mass sort of widespread public use of masks. Here in the United States, masks have been deeply politicized and very divisive. But interestingly in the United States, even though we are a deeply divided nation around many aspects of the response, and masking being one of the most toxic issues, the actual use of masks by Americans continues to rise. People are making that choice. They're listening, they're thinking. Are we seeing that in Sweden? Are we seeing a higher level use of masks on daily, routine use as people circulate? Is it more common now to see, even though that may not be sort of a heavy emphasis of policy and communications to the public?
We don't really have we don't measure it in any way. So, I mean, this is more from personal observations, and from those I would say no. It's very rare to see a person with a mask. I travel with a train to Stockholm, not every day anymore, but quite often. And usually on that train, you see maybe 2 or 3 people with masks, and that's been fairly constant. And I said a majority of those, at least gives the impression of being tourists. So they come from other environments where masks are a lot more common. The sales of masks goes a bit up and down. It seems like as soon as the debate goes on about masks, everybody believes that now there's going to be more recommendations for masks, we better go and buy some. So then the sales goes up for a week and then it goes down again. So no real pressure in that area. And it's, as I said, it's not politicized at all. And of course, there's been certain group of scientists who have argued strongly for it. But when we talk to our specialists out in the regions, with the people who are specialists in hospital hygiene and so on, they are very much in agreement with us. Yes, there is a role for masks in healthcare, in care of the elderly and all of those places for sure. There might also be a role for masks if you can't keep a distance in certain situations, and then the local regions give advice about that. But to sort of advise or try to enforce them in certain settings. We haven't reached that level yet. We still really believe that we can keep a distance. And we can really say that the last regulations or the recommendations we put in place, and also this Prime Minister's talks and so on, really has meant that travel has gone down a lot. We can follow mobile phone operators, and the movements in Sweden has gone down by 40% in the last few weeks. Shopping in major shopping malls has gone down by 25%. Some parts of shops and so on have lost like 50% of their revenues in the last few weeks. So people are really staying home a lot, and they're keeping distance. And I think that most science tells you that keeping distance is a lot more efficient than wearing mask. And then I'm sure we can have long discussions on the different studies that have been done on masks and how reliable they are and so on. But if you read the latest statement from WHO, it's quite clear that it is a difficult area to say where is the evidence, and it's not very strong either way. And the effect is difficult to judge. And of course, that will be very, I think, also depending on the situation, how well you can train the people who are using them, and a lot of other factors that are difficult to measure.
Yeah. Well, here in the United States, as I said, we're very divided, and masking's become toxic and politicized. CDC, though, has issued pretty dramatic and pretty definitive guidance lately that's now becoming sort of the basis of policy in the President-elect Biden's approaches, in the call for 100 days and call for voluntary use and call to governors and mayors to bring about this as a major instrument of control, particularly around asymptomatic transmission, aerosolized asymptomatic transmission. Let me shift a bit to ask about Sweden's performance versus its neighbors. I mean, in Sweden, I mentioned earlier, 279,000 cases, 7,000 deaths, and deaths per million running at 700. If you compare that with Norway, deaths per million are 66, Finland, deaths per million 76, Denmark, deaths per million 154. So a fraction of the levels in Sweden. And in terms of actual total deaths, Sweden at 7,000, Norway at 359, Finland at 424, Denmark at 894. How do you explain these pretty stark divergences between what's happened in Sweden and what's happened in the neighboring states, which there's difference in population levels, there's difference in demographics, but many of them, there's many shared aspects in terms of the health systems and the approaches and the demography and the like. So this is a very stark picture. How do you explain that?
Yeah, and I think it's very difficult to explain completely, and there's a lot of different factors you might discuss around that, and I'm sure a lot of people will spend years into the future to try to put some kind of science and understanding in this, because it is, I think, quite difficult to understand completely. I mean, Norway and Finland had not had really dramatic lockdowns, need Denmark a bit more. But when we look at Europe as a whole now, we need to realize it's not Sweden that's the outlier. It's actually Norway and Finland that's our outliers. They are the ones that differ strongly from all other European countries, while Sweden followed very much the same pattern as many other European countries. I think that the death mortality level in Sweden is now, I think, about the same as the average among European countries. So Sweden is behaving like most other countries, but for some reason, especially Norway and Finland, the death toll and the pandemic has moved quite differently. I think one thing you need to realize is that in those countries, the whole of the population has never been sort of exposed to the spread yet, while it has in Sweden, and now Denmark is also entering that period, the same as many other European countries, while Norway and Finland has had only part of the geography. So there's a much smaller part of the population that's been affected in those countries. One thing we discussed a lot was the massive introduction into Sweden when this whole started up. And that's when I discussed with my UK, Belgian and Dutch colleagues they all say the same thing. This started out as really massive introduction in a way that we have not really ever seen a disease being introduced with so many cases in such a short time. And I think there might be something to that. When you introduce a disease with so many people at the same time, the epidemic becomes really, really big. And we can also see that the areas in Europe that were hard hit during the spring, they were also hard hit now during the fall. There is, of course, countries who were not hard hit in the spring who still were hard hit in the fall, like Czechia and a number of the Eastern European countries. But all of the countries like Belgium, the Netherlands, UK, France, Italy, that had huge numbers of cases in the spring, also had a huge number of cases in the fall. And I think that's another background. Once you have this disease basically spread in all of your population, when then the surrounding factors makes it possible for spreading again, you get a much bigger spread than you do in countries where you only had a limited spread from the beginning. So I don't really know why. There's a number of reasons, of course. The way we treat our elderly homes works is something we discuss a lot in Sweden, because that was, I think, one of the great failures during the spring. That weaknesses in our elderly care really exposed parts of the elderly population very heavily to this disease, and that caused at least 50% of the death toll in Sweden we can attribute to spread in those elderly homes. So there's a number of different factors. It's difficult to completely understand, but at least me personally, I get more and more into trying to understand what makes Norway and Finland different from the rest of Europe, and why did the disease not really affect them as much as others. I mean, most of the European countries have very strict lockdowns, but that did not stop the disease spread to any great extent. While Norway and Finland had semi-hard lockdowns, and they managed to stop the spread very effectively. So it's
how are you coordinating with your neighbors now? I mean, there's some controls over by your neighbors in terms of traffic in and out of Sweden. There's been some barriers imposed, some of the starkest that we've seen in a long time. And the coordination becomes very important, yet your outcomes are so different, and there's now been this tension around border control and ability to move in and out. How are you dealing with that? How's your coordination efforts today?
Yeah, that's on a more political level, and we are not so much involved in that, but it has been a big piece of contention and strain in what's normally a very sort of close collaboration between the Nordic countries. And I think that's another thing that there's going to be quite a lot of discussion around when this ends up, how we ended up in putting these very, very strong barriers between each other. Was that really so necessary? And what kind of effects did it really have on the way we normally collaborate so much with each other? But those parts became very politicized very early on in several of the Nordic countries. And even if we still have a very good collaboration on the technical level, many of those decisions were taken all of those decisions really were taken on a political level.
Let me ask you on the question of elderly homes. I mean, my understanding is that this was a terrible problem and a source of great controversy around the high death rate in the spring. Some of this was rooted in changes that had happened in the early 90s in terms of privatization. Some of it had to do with legal barriers of oversight or weakness of oversight. Many of those who became ill were not brought into hospital service. They died in place. And then you had those that were cared for by municipalities in their homes, and there'd been a depletion of resources around that. All of these are pretty systemic issues and ones that require pretty dramatic, thoughtful changes. How much progress has been possible? And is this still, I assume this is still an enduring set of challenges for trying how to how to better protect and serve those populations, the elderly populations in Sweden, whether they're at home in care of municipal support or in an institutional setting.
No, definitely. It's also been very much in focus when we discuss what we're going to do after the pandemic. And we currently have a political Corona Commission in place. And the first task of that commission was really to look at the care of the elderly and how that could be improved. And they are due to deliver their report within a week or two, I think, to start the discussion around this. As you said, this is really a long-term issue. The treatment of the long-term ill people were moved from the regions to the communities some 30 years back. And they were then treated in a kind of home setting, or a mixture of a home setting and a kind of facility setting, but it's still officially their home. And the communities take care of them. But the level of medical expertise and the medical resources in those elderly homes is very weak. And that's been pointed out repeatedly over time, but unfortunately never really led to any big changes. So, I mean, there's still a discussion on exactly what is the main reason behind this, but certainly one of the reasons is that medical expertise, medical resources connected to those elderly homes were not strong enough. So that's at least one reason. And what will happen now after the commission and what the government is going to do about that still remains to be seen. But for certain, some kind of changes need to be put in place. They have improved a lot, one must say, by educating the staff better, getting better access to testing and contact tracing in those places, improving the staff's possibilities to stay home when they are sick and so on. So there's been a number of, I think, very important changes put into place. And we still see a fair amount of death toll in those, but it's far away from what we saw this spring. So we do believe that they are better prepared now. But there are, as you said, there are systemic problems in the way we have set up the long-term care facilities in Sweden that really needs to be rectified.
Thank you. I'd like to talk for a moment about immigrants. In the United States, of course, our Black, Latinx, Native American, migrant communities have suffered disproportionately on the COVID-19, and it's exposed a very unsettling reality in American society, which is that these populations, these communities, for a variety of reasons, are acutely vulnerable and poorly served and poorly connected to the health system. And they get sick, they have severe illness, and they die at rates that are well in excess of what are seen as the general population. What has been the experience with the immigrant community within Sweden? And is this a topic similar to what we're seeing in the United States? And is it one that's under consideration by the Commission that you just referenced?
We definitely have a very similar experience, I would say. About 20% of the Swedish population are born in another country than Sweden. So we still have, or we do have I think, much bigger migrant community than most people outside of Sweden realize. Sweden has really changed during the last 30, 40 years in that way, and very much to the better. But the integration of those groups have not really been gone as far as we could have hoped for, because they are still very much living in socioeconomic worse off areas, as you're alluding to. They're living in cramped quarters. They live together with different generations, very cramped together. They have the kind of work where you meet a lot of people and expose yourself to disease a lot more than others. They often have employment conditions that makes it more difficult for them to stay home when they are sick. So there are many different factors. And of course, none of these are really related to ethnic background or anything else like that, but it's basically connected to socioeconomic issues in different ways. So they are also definitely overrepresented in the Swedish statistics, very unfortunate. So a lot of efforts have been made to reach them better with information on how to protect themselves and how to avoid risks and so on. But these socioeconomic circumstances, of course, cannot be changed overnight. I would say it has not been discussed that much in Sweden yet, but I think we are coming there eventually when we are putting more and more emphasis on that. And it's definitely, I think, taken up as part of the, I wouldn't say failure, but how long time it takes to be integrated into Swedish society, especially with the later groups of migrants, not with the ones that came like 20, 30 years ago, came from South America, Yugoslavia, and so on. They are very much and very well integrated. But these are groups from the Middle East, from Africa's Horn, and they have not been integrated as well as many others, and they really have suffered a lot more than the population at large. And we're still struggling trying to find out what we could do about that, but it's a difficult issue.
Thank you. I'd like to shift to preparations for the introduction of vaccines. We had the first introduced in the UK yesterday. We have processes unfolding here in Washington, D.C. that are likely to result in the introduction of the first vaccines very soon, in the next few days. This has people very excited. It poses all sorts of very complicated logistical demands. It poses all sorts of issues of prioritization, allocation. How do you manage expectations? How do we phase this in a way that makes sense, that is accepted by the general population as a need, because patience is going to be very important, and we know there's going to be delays and complexities in all of this. Tell us a bit about how the preparations stand in Sweden.
I think this is where the European Union has really done a good work, because European jointly has procured vaccines. And we are now waiting for the European Medical Agency to take the first step towards approval, and then the Commission to take the decision on that a few days later. If it all goes to plan, the first vaccine will be ready to roll out around the first days of the new year, a couple of weeks ahead. UK started on earlier with an exception from this complete sort of agreement. Right. On the safety of the vaccines. None of the other European countries are going that way. I think all of us are jointly together thinking we need to go the normal way. We need to assure the population of the complete safety of these vaccines that are now coming. So we're waiting for the full procedure to come in place. And then it will roll out jointly all over, or in most European countries at the same time. So we will hopefully get our first doses of vaccine very early after New Year's. And we are putting plans into place. Once again, this is a regional matter to a great extent in Sweden, since the regions are running the healthcare services, which are the ones that has to deliver the vaccine. They are, I would say, reasonably well prepared for this, because they run a similar exercise every year when it comes to flu vaccine. This is, of course, bigger, but in many ways similar. We have issued guidance on how to do priorities. The first level of priorities will be these long-term care facilities and the staff there, because we really want to break the spread we have seen there and the danger of mortality and high level of morbidity we get in those places. So that will be the first level of priority. The second level of priority will be other risk groups, mainly everybody above 70 years of age. And then we will move to the population at large and see exactly how we run that. That depends a little bit on how and when we get vaccines. Currently, we have, I think, contracts with at least 5 different vaccine suppliers that will start supplying vaccines at different times. So this will be a logistical, I was almost saying nightmare, but that's taking it a bit far maybe, but it would definitely be a challenge to be able to run 5 different vaccines at the same time, when most of them all of them, as far as we know, need 2 doses. It needs to be 2 doses of the same vaccine. Some of them need to be kept in -70. Some of them can be kept in refrigerators. So it's, this is going to give a lot of people a few gray hairs, I think, before we're through this. But I think we are fairly confident that the system in Sweden we did this during the swine flu pandemic, and the healthcare service did a fantastic job. We reached, I think, 55% of the population in those days, which I think was a world record. I think no other country reached as far as we did. Of course, we had a dramatic narcolepsy incident at the same time, which was very unfortunate, because that really, I think, took away the fantastic work that was done during the mass vaccination at that time, that these poor children were affected in this negative way. But it shows, I think, that the setup of the Swedish system can handle mass vaccination in a very efficient manner.
Now, there's a lot of apprehension here in the United States around vaccine hesitancy, vaccine refusal, the polluted digital environment in which you have active disinformation, misinformation, anti-vaccine movement, all sorts of other players that are creating an environment of falsehoods and confusion, and how you cut through that. Is that going to be a problem in Sweden?
Yeah, probably. We have been reasonably lucky when it comes to those groups so far. They're definitely heard in Sweden, but their impact has been very low so far. Our childhood vaccination program reached some 96, 97, 98% of every child born in Sweden, in spite of people being a bit more hesitant these days. Still, almost all parents take their children to be vaccinated. We reach, I think, 55, 60% of all the elderlies during the flu vaccine campaigns and so on. But definitely these are groups to take very seriously. And we are definitely working very hard with putting together communication and information campaigns to counter those kind of groups when they start up. We can see them moving slightly already. But I think in the last surveys, at least, I think it was around 70% of the Swedish population said they would get vaccinated once a vaccine came into place. And I believe that's quite a high level of trust when we don't know very much about the vaccine yet, and so little is known about it. Still, so many people are saying that they will definitely get vaccinated. So I think it will be an issue here, but not at all as bad as it looks in the US, I would say.
Yeah, and as you think out about 2021, the rollout of the vaccines, what are you thinking in terms of reaching a level of herd immunity within the Swedish population in terms of the timeline? Are you looking at second, third, fourth quarter of 2021? How's your thinking right now?
If the deliveries are done as the contracts say, and that these vaccines do get approved according to the timelines that are put in place, we believe that we could vaccinate the risk groups within 1 to 2 months. And then we could reach major part of the population within the next 3 or 4 months. So by next summer, there should be, if we can get this to roll out and everybody accepts getting vaccinated, and all these caveats, we should have a fairly high level of immunity by next summer.
Okay, thank you. I think that timeline isn't that far off of the timeline, the very ambitious timeline in the United States, which of course is much different scale and set of problems. Let me ask you a few questions about your own personal background, which is quite unusual. And I really wanted to get at sort of how that shaped your thinking, because as a child, you were raised in Ethiopia. And then as you became a professional practicing public health and medical expert, you worked in Laos, you worked with WHO, you found yourself working in then Zaire, now Democratic Republic of Congo, during the 1995 Ebola outbreak in Kikwit, which was a big urban center where you had a very dangerous outbreak. You spent time working in the EU and the European Union on some of its Europe-wide policies. You, in your job today, you're involved in partnerships overseas, the reference lab in Mogadishu, with the Somali government and other international. Obviously, these interests are very live ones for you in terms of your looking at those environments and bringing your skills to bear. How has all of this shaped your thinking at home in Sweden in this period of thinking about COVID-19 and how to structure the response?
Yeah, that's a good question. I haven't really thought about it that much, but I think that has really pushed me in the direction of thinking about population health. That because as a physician, as a doctor, you are trained and mainly directed towards treating individuals and patients, and that's of course the thing to do as a doctor, to save your patients and treat them and make them well again. But after this sort of working in Laos and other places, I became a lot more interested in population health. And I think that's more different than many people think, because you have to think in many ways differently than when you think about an individual. And I think that's really and that's also why I kept the interest on the international scale, because I think when you work in other countries and what maybe richer countries can really help poorer countries with is really to put systems in place to increase their population health, to look at how we can have systems in place, procedures in place to prevent disease and to work with the population level of health, which I think is so important. And I think that's also to a certain extent made many of the choices we have made in Sweden easier. And that's definitely not only me. I work in a public health agency where population health is really the focus of what we are doing. We are not working with hospitals or hospital treatment and so on. But we are all the time trying to think about, okay, what can we do to keep our population healthy? And I think our prime example is really the schools that you mentioned that we kept open. And it's because we know that schools are so incredibly important for children's health, both on the short term, because many deprived children, this might be the one place they can feel safe during the day where they get good food and all of these kind of things. But also we know that at least in Sweden, finishing school is the one most important thing you can do to have a healthy life. Because if you do finish school with reasonable grades and so on, you go into society and you get a good work and you get much better health than anybody else in society. And that's why weighing what we thought and still think are the small consequences of keeping schools open for the spread of the pandemic, what you can gain by keeping children in school is so much more important. And of course, that also reflects to many of the poorer countries where schools are even more important, and where closing schools now have really caused major effects that's probably going to take a long, long time to repair.
Thank you. I want to pivot from this to talk about vaccine equity and access by low and middle income countries to vaccines. I mean, you talked earlier about the EU forming up a very strong effort to do the pre-purchase on mass scale of 5 different vaccines. The US has Operation Warp Speed. The UK has engaged in very similar practice. The Chinese, the Russians are doing something quite similar. And so when you look at the most wealthy and powerful countries in the world, including Canada, Japan, Australia, over 4 billion doses of vaccines have been pre-purchased to serve those populations, to make sure that they have adequate supplies to take care of their populations. And in the middle of a crisis, it's a very nationalistic sort of approach, and we shouldn't be too surprised by that. But many have also pointed out that there has to be a universal solution to this problem, and that you have to be able to arrest the pandemic everywhere in order for all of us to be safe. And so the ACT accelerator, and within that, the COVAX facility for vaccines has become a big subject of discussion and debate. And Gavi Alliance and CEPI working very aggressively to build support around that. Tell us a little bit. I know this falls largely within the Foreign Affairs Ministry in Sweden, but I'm sure you have an advisory role on all of this. And how active will Sweden be in attempting to make the ACT accelerator successful, and particularly the vaccine facility, to bring forward adequate supplies, adequate financing, and surplus vaccines to that facility in this next period? It's going to be an urgent requirement in 2021 and beyond. We're going to be struggling with this problem for the next several years.
No, you're completely right. I mean, we can't solve a pandemic by focusing on what we're doing in our own countries. We really need to take a broader view on that. And I think Sweden, the public health agency, is not really very much engaged in this, but Sweden has taken a very strong position on that. And our prime minister has issued a statement together with the commission on how important it is to really see to it that in the work we're now doing together in EU, in trying to get the supply to the EU countries, we also see to it that as a side benefit of that, we will also support the COVAX and different things that are in place that will make it possible for also providing vaccines for the poorer countries. And I think that's incredibly important. I'm very sure that irrespective of further governments in Sweden, Sweden will definitely push for this as much as we can as a small country.
Thank you. We've got a few minutes left. I want to shift to the question of whether we're entering a period of a kind of convergence of outlook. And what I mean by that is, if you look at the conditions and the policies in place here in Washington, D.C., and you look at the conditions and policies in place in Stockholm, they're not very different. And when you look at the thematics across many different countries today, we see rising internal debates like you face. You have a more divided society today than you did 10 months ago in debating what is the way forward, where you have political divisions, you have media, you have debates within the scientific and public health community. We have plenty of divisions and debates going on here, and a discussion around how do you forge a new national consensus to go forward. We know that we struggle with this balance. What's the balance between having restrictions in the face of a surge and the risk of a broken health system versus not imposing too heavy a cost on schools and on businesses and on society? There's been different moments in which herd immunity looked like it was going to be a factor, but it's now receding in visibility as a consideration, as we realize that, first of all, the numbers are not rising, and the solutions are going to come through behavior and through vaccines and other measures. We're all focused in the Northern Hemisphere on getting through this surge and through this holiday season without having runaway problems. And we see national leadership, as we talked about, in Sweden, we're seeing national leadership stepping forward in new and different ways. I just wanted to ask you, as you look at what's happening in Sweden and what's happening globally, do you agree? Are we entering this period of a different kind of convergence and a different type of debate?
Yeah, I think you're right to some extent. First, I would like to say that we don't really have a big division in Sweden. It might look like that in the debate in the media and so on, but when we go out and ask the Swedish population, 80-90% of the Swedish population says that keep on following the advice from the political level and the government and the agency. And the level of trust in the agency and in the political level is still up at 70-75% of the population, which is the highest we ever had. So the division is not in the population in Sweden, is to a certain extent between the political parties and in the media, just to start off with that. But otherwise, I think, yeah, you're right. We are going to becoming more and more alike. And I think that's a good thing, because that might make sort of the life after COVID-19 a bit easier, because we might realize that we did different things. We did them in good faith. We really tried to control this as best as we could. But in the end, many of the things we did might not have all that much of an effect. And I think that will make the discussion on how to go on into the future a bit easier. And yes, I mean, Sweden has changed, as you've been alluding to. We have become a bit stronger in certain ways. Our political level have stepped out a bit more than they did in the spring. So we are moving in that direction, while other countries have moved towards Sweden, keeping schools open, trying to be a bit more focused on what to close down, not having these kind of complete lockdowns that were so popular in the spring. So yes, I think that the differences, which I think has always been a bit overstated, because they were not that great in the spring either. But the differences are becoming smaller, which also makes kind of sense, because when we know more and more about the disease, it will be more and more evident what is the best things to do and what things will not work.
In retrospect, looking back over we're getting towards the end of the year. It's been an incredible year, a painful year, a difficult year, an astonishing year for the world. And as you reflect on this year, what do you think should have been done differently if you were equipped with the knowledge you have today, versus getting thrust into the middle of this dangerous set of unknown challenges, which is always going to be fog of war. But now there's a little bit more visibility into in a little more knowledge. Equipped with that, what would you have done differently looking back?
I think you can look at it at different levels. I think on the international level, even if there was a fair amount of collaboration, and WHO in many ways did a good work, I think we could have done a lot more collaboration in the beginning to try to be better at trying to understand the disease quicker and trying to get agreement on what is a good way of handling this disease in a more reasonable debate. It became very politicized very quickly. We saw what happened in China, and that sort of spread a kind of knowledge that closing down is the only thing you can do. There is no other options. So I think if we had, at least on a technical level, had been able to spend a bit more time on discussing what are the right things to do, how do we actually collect data together so that we better understand this disease quicker than we did at this stage, because many of the things took a bit too long before we realized a number of the issues with this disease that could have been realized quicker and earlier with a better international collaboration, I think. In Sweden, I think there's a lot of lessons to be learned. Some of them are obvious, and we talked quite a lot about elderly care, elderly homes, where we need to do a lot of things. There is also the preparedness in the health sector. Even if the Swedish health sector managed in an admirable way to change, they doubled their capacity of ICU beds within a few weeks and so on. It took a lot of effort. If we had been a bit better prepared, had a little bit more stocks in place and so on, the stress around that would have been a lot easier on many of us. So I think that's definitely a learning way there. And I think we need to go back and look at the schools again to try to understand even better what we need to do in schools to minimize the spread there and really manage to keep them open without so much anxiety that the schools have caused in many countries, even if the actual disease has not caused that much problems in school. The anxiety has caused a lot of problems in the schools that we should have been able to deal better with. So there's many things we can learn, I think. I think in Europe, we're trying to understand how we can also be better at doing things collectively. All of these travel measures and so on put in place between the different European countries was not, I don't think, all that effective and caused a lot of problems, maybe to a certain extent unnecessary problems. And once again, we need to learn something there so that we react in a reasonable manner, not overact, not underact in the future in these kind of situations. So I think we're going to spend quite a lot of time in the future, I hope, in rectifying a number of things. Unfortunately, the history tells us that this might not happen. I've been in a number of follow-up meetings over the years after these kind of disasters, and in the end we look at each other and said, okay, this is exactly what we discussed 5 years ago after Ebola in West Africa. And I hope we're not going to have the same meetings this time, that we instead say, okay, we actually moved a step forward.
I agree. We're getting to the end of the hour here. I'd like you to close and just give us a sense of what gives you the greatest optimism looking forward. What gives you the greatest hope and optimism looking forward?
No, I mean, we're a bit worried about that the effects of the vaccine will be overstated. So we've been trying to calm that down. But in the end, of course, vaccine will make a lot of difference if it works the way it looks like it works and if we can handle it in a good way. So I think the reason for optimism right now is really the vaccine. If we can get that to work well, if we can give our populations good enough information and so on that they will accept to be vaccinated. I think this can make a huge difference. Even if we need to realize it's not going to be the complete solution. It's not going to get rid of the disease for us. We're going to have to live with this disease for a long time, I think. But at least we can control it in a way so that we don't need to see the kind of death toll and so on in our elderly homes that we've seen in Sweden in the future.
Dr. Tegnell, thank you so much for taking the time today to be with us. And thank you for your patience with all of these questions and your candor. And thank you for your service. And we wish you the best of luck going forward and the safest and joyous holidays.
I wish you the same. Hope to see you.